Question 1. A critical care nurse is caring for a patient admitted with acute decompensated heart failure. The patient's assessment reveals dyspnea at rest, orthopnea, crackles bilateral lung bases, and an S3 heart sound. Which of the following hemodynamic parameters would the nurse anticipate being elevated? A. Systemic vascular resistance, SVR. B. Cardiac index, CI. C. Pulmonary artery wedge pressure, PAWP. D. Mixed venous oxygen saturation, SVO2. Answer, C. Pulmonary artery wedge pressure, PAWP. This question tests your understanding of acute decompensated heart failure and its hemodynamic presentation. The keywords dyspnea at rest, orthopnea, and crackles point to fluid overload and increased left ventricular filling pressures. An elevated pulmonary artery wedge pressure, PAWP, which directly reflects left ventricular end diastolic pressure, is a hallmark sign of left-sided heart failure and pulmonary congestion. For example, a normal PAWP is typically 4 to 12 millimeters of mercury, so a reading of 20 millimeters of mercury or higher would confirm this finding. Remember, increased PAWP indicates the left ventricle is struggling to pump blood forward, leading to a backup of pressure into the pulmonary circulation. Question 2. A patient presents to the emergency department with acute chest pain radiating to the left arm and jaw. An ECG shows ST segment elevation in leads 2, 3, and AVF. Which coronary artery is most likely occluded? A. Left main coronary artery. B. Left anterior descending artery. C. Circumflex artery. D. Right coronary artery. Answer, D. Right coronary artery. This question focuses on correlating ECG changes with the location of a myocardial infarction and the specific coronary artery involved. The keywords ST segment elevation in leads 2, 3, and AVF indicate an inferior wall myocardial infarction. The right coronary artery, RCA, typically supplies the inferior wall of the left ventricle, the right ventricle, and the SA and AV nodes, making its occlusion the most likely cause of these ECG changes. Understanding which leads correspond to specific myocardial regions is crucial for rapid diagnosis and intervention. A helpful tip is to remember inferior MI equals 2, 3, AVF equals RCA. Question 3. A patient in cardiogenic shock is prescribed an intra-aortic balloon pump, IABP. The nurse understands that the primary goal of IABP therapy is to improve myocardial oxygen supply and demand by which two mechanisms? A. Increasing afterload and decreasing preload. B. Decreasing cardiac output and increasing heart rate. C. Increasing coronary artery perfusion and decreasing afterload. D. Decreasing systemic vascular resistance and increasing contractility. Answer, C. Increasing coronary artery perfusion and decreasing afterload. This question assesses knowledge of the physiological effects and therapeutic goals of an intra-aortic balloon pump, IABP. The IABP works by inflating during diastole, which increases coronary artery perfusion, and deflating just before systole, which creates a vacuum effect to decrease afterload, thereby reducing the workload on the left ventricle. This dual action is crucial for improving the oxygen balance in a failing heart. For instance, by reducing the resistance the heart has to pump against, the IABP allows the weakened ventricle to eject blood more easily while simultaneously ensuring the heart muscle receives more oxygen-rich blood. A good way to remember this is IABP, less work for the heart, more oxygen for the heart. Question 4. A nurse is preparing to administer adenosine to a patient experiencing supraventricular tachycardia, SVT. Which of the following actions is most critical immediately after administering the medication? A. Administer a normal saline flush rapidly. B. Assess the patient's peripheral pulses. C. Obtain a 12-lead ECG. D. Prepare for immediate cardioversion. Answer: A. Administer a normal saline flush rapidly. This question tests the nurse's knowledge of the correct administration technique for adenosine, a drug used to treat supraventricular tachycardia, SVT. Adenosine has an extremely short half-life, typically less than 10 seconds, which means it needs to reach the heart quickly and in a concentrated bolus to be effective. Administering a rapid normal saline flush immediately after the adenosine ensures the medication is propelled into the central circulation and reaches the heart before it can be metabolized. Without a rapid flush, the adenosine may not reach the heart in sufficient concentration to terminate the SVT. Always remember that for adenosine, push fast, flush fast. Question 5. A patient undergoing a percutaneous coronary intervention, PCI, via the femoral approach has a femoral sheath in place. Post-procedure, the nurse notes pulsatile bleeding around the sheath insertion site and a rapidly expanding hematoma. What is the nurse's immediate priority action? A. Apply a pressure dressing to the site. B. Notify the physician immediately. C. Hold manual pressure directly over the arterial puncture site. D. Assess the patient's distal pulses. Answer: C. Hold manual pressure directly over the arterial puncture site. This question presents a critical post-PCI complication, which is a retroperitoneal hemorrhage or significant arterial bleed from the access site. The keywords pulsatile bleeding and rapidly expanding hematoma indicate an urgent arterial compromise. The immediate priority is to control the bleeding by applying direct, firm manual pressure over the arterial puncture site, typically 1 to 2 inches above the visible bleeding, while simultaneously calling for help. This action takes precedence over other steps, as uncontrolled bleeding can quickly lead to hypovolemic shock. After controlling the bleeding, then you can more safely assess distal pulses and notify the physician. Question 6. A patient is admitted with hypertrophic cardiomyopathy, HCM. The nurse understands that a key educational point for this patient regarding physical activity is to avoid A. Low-intensity aerobic exercises. B. Moderate-intensity walking. C. Strenuous competitive sports. D. Daily stretching routines. Answer: C. Strenuous competitive sports. This question focuses on patient education for hypertrophic cardiomyopathy, HCM, a condition characterized by abnormal thickening of the heart muscle. In HCM, strenuous physical activity, especially competitive sports, can worsen outflow obstruction, increase myocardial oxygen demand, and precipitate dangerous arrhythmias or sudden cardiac death. While low to moderate intensity activities might be permissible for some, the general recommendation is to avoid intense exertion to prevent adverse cardiac events. For example, a patient with HCM should be advised against activities like competitive basketball or long-distance running. The crucial takeaway is to emphasize avoiding high-intensity activities that significantly increase cardiac workload for patients with HCM. Question 7. A patient with a history of heart failure is prescribed spironolactone. The nurse should closely monitor the patient for which electrolyte imbalance? A. Hypernatremia. B. Hypokalemia. C. Hyperkalemia. D. Hypomagnesemia. Answer: C. Hyperkalemia. This question tests your knowledge of common medication side effects, specifically for spironolactone, a potassium-sparing diuretic often used in heart failure management. Spironolactone works by blocking aldosterone, which leads to increased sodium and water excretion, but also retains potassium. Therefore, the nurse must closely monitor for elevated potassium levels, or hyperkalemia, which can cause life-threatening cardiac arrhythmias. A practical example would be checking daily labs and recognizing a potassium level of 5 milliequivalent/L or higher as a significant concern. Always remember that spironolactone spares potassium, meaning it helps the body hold on to potassium, increasing the risk of hyperkalemia. Question 8. A patient is on a continuous norepinephrine infusion for septic shock. The nurse notes the patient's mean arterial pressure, MAP, has increased from 60 millimeters of mercury to 85 millimeters of mercury, but the patient's urine output has decreased significantly, and distal pulses are weaker. What is the most likely cause of these findings? A. Inadequate fluid resuscitation. B. Excessive vasopressor effect. C. Developing cardiogenic shock. D. Progression of sepsis to MODS. Answer B. Excessive vasopressor effect. This question assesses the nurse's ability to recognize the adverse effects of vasopressor medications, specifically norepinephrine, in a patient with shock. While norepinephrine is effective at increasing MAP, an excessive vasopressor effect can lead to profound vasoconstriction, diverting blood flow away from critical organs like the kidneys and extremities. The clues, decreased urine output and weaker distal pulses, despite an improved MAP, strongly suggest this overconstriction. This scenario highlights that achieving a target MAP with vasopressors is not the only goal. Adequate tissue perfusion must also be maintained. When using vasopressors, it's vital to balance blood pressure support with maintaining organ perfusion. Question 9. A patient is admitted with a new onset of atrial fibrillation with a rapid ventricular response, RVR, at 150 bpm. The patient is hypotensive, BP 80/40 mmHg, and experiencing altered mental status. What is the most appropriate initial intervention? A. Administer 4-diltiazem. B. Prepare for synchronized cardioversion. C. Administer 4-amiodarone. D. Initiate a fluid bolus. Answer B. Prepare for synchronized cardioversion. This question focuses on the immediate management of unstable atrial fibrillation with a rapid ventricular response. The keywords hypotensive and altered mental status signify hemodynamic instability, which is a critical indicator for immediate intervention. In this unstable scenario, pharmacological interventions like diltiazem or amiodarone are too slow. Instead, synchronized cardioversion is the definitive treatment to quickly restore sinus rhythm and improve cardiac output. This rapid electrical intervention aims to prevent further decompensation and stabilize the patient. For unstable tachyarrhythmias, remember the rule. If they're unstable, shock them. Question 10. A patient following cardiac surgery has a chest tube draining sanguineous fluid. The nurse observes a sudden decrease in chest tube output, muffled heart sounds, jugular venous distension, JVD, and hypotension. These findings are most indicative of A. Postoperative atelectasis. B. Pulmonary embolism. C. Cardiac tamponade. D. Pleural effusion. Answer C. Cardiac tamponade. This question describes the classic signs of Beck's triad, which is highly indicative of cardiac tamponade, a life-threatening complication where fluid accumulates around the heart, compressing it. The keywords sudden decrease in chest tube output, suggesting a clot is blocking the tube and fluid is accumulating internally, muffled heart sounds, jugular venous distension, JVD, and hypotension collectively point to this condition. In cardiac tamponade, the heart cannot fill properly, leading to decreased cardiac output and shock. Recognizing this triad is crucial for urgent intervention, as it requires pericardiocentesis or surgical drainage. Question 11. A patient with chronic heart failure has a pulmonary artery catheter, PACI, in place. The nurse notes the following readings. Cardiac output, CO. 3, 5L/min, cardiac index, CI. 1, 8L/min/m superscript 2, systemic vascular resistance, SVR. 1800 dynes/SEC/cm, and pulmonary artery wedge pressure, PAWP. 22 mm of mercury. These findings indicate A. Hypovolemic shock. B. Cardiogenic shock. C. Septic shock. D. Neurogenic shock. Answer B. Cardiogenic shock. This question tests your ability to interpret hemodynamic parameters in the context of different shock states. The combination of low cardiac output, CO. 3, 5L/min and cardiac index, CI. 1, 8L/min/m superscript 2 inch indicates severe pump failure, while a high systemic vascular resistance, SVR. 1800 dynes/SEC/cm reflects the body's compensatory vasoconstriction and an elevated pulmonary artery wedge pressure, PAWP. 22 mm of mercury confirms increased left ventricular filling pressure due to the heart's inability to eject blood. These specific parameters are classic indicators of cardiogenic shock, where the heart fails to pump enough blood to meet the body's demands. Remember, low CO/CI combined with high SVR and high PAWP strongly suggests the heart itself is the problem. Question 12. A patient is admitted with an STEMI, non-ST elevation myocardial infarction. Which of the following lab markers is the most specific indicator of myocardial damage? A. Myoglobin. B. Creatine kinase MB, CKMB. C. Troponin I. D. C-reactive protein, CRP. Answer C. Troponin I. This question assesses knowledge of cardiac biomarker interpretation in acute coronary syndromes. While myoglobin rises early and CKMB is also indicative of muscle damage, troponin I is the most specific and sensitive biomarker for myocardial injury. Troponin I levels elevate within a few hours of myocardial cell death and remain elevated for an extended period, making it the preferred diagnostic marker for STEMI. For example, if a patient has a muscle injury from a fall, their CKMB might be elevated, but their troponin I would remain normal if their heart was unaffected. Always remember that troponin is the gold standard for detecting heart muscle damage. Question 13. A patient with a history of rheumatic fever develops sudden onset dyspnea, fatigue, and orthopnea. On assessment, the nurse notes a loud S1 and a diastolic murmur at the apex. These findings are most consistent with A. Aortic stenosis. B. Mitral regurgitation. C. Mitral stenosis. D. Tricuspid regurgitation. Answer C. Mitral stenosis. This question tests your understanding of valvular heart disease, specifically mitral stenosis. The keywords rheumatic fever, a common cause, dyspnea, fatigue, orthopnea, symptoms of pulmonary congestion, loud S1, and a diastolic murmur at the apex are all classic signs of mitral stenosis. In this condition, the mitral valve narrows, obstructing blood flow from the left atrium to the left ventricle, leading to increased left atrial pressure and pulmonary congestion. For instance, the loud S1 occurs because the stiff valve closes forcefully, and the diastolic murmur is heard as blood is forced through the narrowed opening during ventricular filling. Remember to link rheumatic fever with valvular damage, especially mitral stenosis. Question 14. A nurse is caring for a patient post-cardiac arrest who remains comatose. Targeted temperature management, TTM, is initiated. What is the primary goal of TTM in this patient? A. To reduce the risk of rearrest. B. To minimize myocardial oxygen demand. C. To improve neurological outcomes. D. To prevent infection. Answer, C. To improve neurological outcomes. This question focuses on the purpose of targeted temperature management, TTM, in post-cardiac arrest care. The primary goal of TTM, which involves carefully cooling a patient's body to a specific temperature range, is to improve neurological outcomes by reducing cerebral metabolic rate and protecting brain cells from injury following ischemia and reperfusion. While other benefits might exist, the most significant and evidence-based reason for TTM is neuroprotection. For example, cooling the body slows down cellular processes that can cause brain damage after blood flow is restored. Remember that TTM is primarily a brain protective strategy in post-cardiac arrest patients. Question 15. A patient with severe aortic stenosis is scheduled for a transcatheter aortic valve replacement, TAVR. The nurse understands that preoperative teaching should include the risk of which common complication related to the procedure? A. Pulmonary embolism. B. Stroke. C. Kidney failure. D. Deep vein thrombosis. Answer, B. Stroke. This question addresses the specific risks associated with transcatheter aortic valve replacement, TAVR. While all options represent potential complications in critically ill patients, stroke is a particularly relevant and significant risk associated with TAVR. The manipulation of catheters and the deployment of the new valve can dislodge atherosclerotic plaques or create debris, which can then embolize to the cerebral circulation, leading to a stroke. For example, during the procedure, calcified fragments from the diseased valve can break off and travel to the brain. When educating patients about TAVR, it's essential to highlight the risk of stroke as a key potential complication. Question 16. A patient is experiencing ventricular tachycardia, VT, with a pulse, but is hypotensive and dizzy. What is the most appropriate initial treatment? A. Amiodarone 4 push. B. Lidocaine 4 infusion. C. Synchronized cardioversion. D. Procainamide 4 infusion. Answer, C. Synchronized cardioversion. This question assesses the management of unstable ventricular tachycardia, VT, with a pulse. The keywords hypotensive and dizzy indicate that the patient is hemodynamically unstable, even though a pulse is present. In any unstable tachyarrhythmia, synchronized cardioversion is the immediate intervention of choice to restore a stable rhythm and prevent further hemodynamic compromise. While antiarrhythmics might be used for stable VT, they are not appropriate as a first-line treatment for unstable patients. For instance, waiting for a medication to take effect could lead to cardiac arrest. Remember, if the patient is unstable with a pulse, cardiovert. If they are unstable and pulseless, defibrillate. Question 17. A patient with a history of a STEMI 2 days ago suddenly develops a new harsh holosystolic murmur best heard at the apex, accompanied by acute pulmonary edema and hypotension. Which complication is most likely occurring? A. Pericarditis. B. Dressler's syndrome. C. Ventricular septal rupture. D. Acute mitral regurgitation. Answer, D. Acute mitral regurgitation. This question describes a critical mechanical complication following a myocardial infarction. The combination of a new harsh holosystolic murmur best heard at the apex, along with acute pulmonary edema and hypotension within days of a STEMI, strongly suggests acute mitral regurgitation. This often results from papillary muscle dysfunction or rupture, which is a complication of an inferior wall MI, RCA occlusion. The sudden inability of the mitral valve to close properly causes blood to flow backward into the left atrium during systole, leading to rapid pulmonary congestion and decreased forward cardiac output. Recognizing this specific cluster of symptoms is vital for prompt diagnosis and intervention. Question 18. A nurse is assessing a patient with a permanent pacemaker. The patient's ECG shows pacemaker spikes that are not followed by a QRS complex, despite an intrinsic rhythm slower than the set rate. This indicates A. Failure to sense. B. Failure to capture. C. Oversensing. D. Undersensing. Answer B. Failure to capture. This question tests your understanding of pacemaker malfunctions. The scenario describes pacemaker spikes that are not followed by a QRS complex, which means the electrical impulse is being delivered but the heart muscle is not responding by contracting. This specific malfunction is known as failure to capture. For example, if the pacemaker is set to pace at 70 BPM, and you see a spike but no QRS for a beat, that's a failure to capture. This can be due to lead displacement, increased pacing threshold, or myocardial injury. When you see a spike but no beat, think failure to capture. Question 19. A patient is prescribed dobutamine for acute decompensated heart failure. The nurse understands that dobutamine primarily improves cardiac output by A. Decreasing heart rate. B. Increasing systemic vascular resistance. C. Increasing myocardial contractility. D. Decreasing preload. Answer C. Increasing myocardial contractility. This question focuses on the mechanism of action of dobutamine, a commonly used inotropic agent in critical care. Dobutamine primarily acts as a beta-1 adrenergic agonist, which increases myocardial contractility, inotropic effect, thereby enhancing the heart's pumping ability and improving cardiac output. While it may have some mild vasodilatory effects, its main role is to strengthen heart muscle contraction without significantly increasing heart rate or oxygen demand as much as other agents. For instance, a failing heart struggling to pump blood can benefit from dobutamine's boost to its pumping strength. The key takeaway is that dobutamine is a positive inotrope, making the heartbeat stronger. Question 20. A nurse is monitoring a patient's arterial line waveform. The nurse notes a dampened waveform with a loss of the dicrotic notch. What is the most appropriate initial action? A. Administer a bolus of 4 fluids. B. Increase the flush bag pressure. C. Check for kinks in the tubing or air bubbles in the system. D. Re-zero the transducer. Answer C. Check for kinks in the tubing or air bubbles in the system. This question addresses a common issue with arterial line monitoring, a dampened waveform. The keywords dampened waveform and loss of the dicrotic notch indicate a problem with the system's ability to accurately transmit the pressure wave. The most appropriate initial action is to troubleshoot for mechanical issues, such as kinks in the tubing or air bubbles in the system, or even a clot at the catheter tip. These mechanical problems interfere with accurate pressure readings and can often be easily resolved without invasive steps. For example, a small air bubble can significantly alter the waveform, making the readings unreliable. Always check the physical setup before adjusting other parameters. Question 21. A patient develops chest pain that is relieved by rest and nitroglycerin, and is predictable with exertion. This description is most consistent with A. Unstable angina. B. Prinzmetal's angina. C. Stable angina. D. Myocardial infarction. Answer C. Stable angina. This question tests your understanding of the different types of angina. The keywords relieved by rest and nitroglycerin and predictable with exertion are classic descriptors of stable angina. Stable angina occurs when the heart's demand for oxygen exceeds the supply, typically during physical activity or stress, but the symptoms are consistent and resolve with reduced workload or medication. Unlike unstable angina, stable angina does not indicate an immediate myocardial infarction. For example, if a person always gets chest pain when climbing 2 flights of stairs, but it goes away with rest, that's stable angina. Remember, stable angina is predictable and relieved by rest or nitro. Question 22. A patient with a history of hypertension is admitted with a blood pressure of 220/120 mmHg, headache, and blurred vision. The nurse anticipates the immediate administration of which class of medication? A. Beta blocker, for example, metoprolol. B. ACE inhibitor, for example, lisinopril. C. Vasodilator, for example, nitroprusside. D. Calcium channel blocker, for example, amlodipine. Answer C. Vasodilator, for example, nitroprusside. This question describes a hypertensive crisis, specifically a hypertensive emergency, given the severe blood pressure elevation, 220/120 mmHg, accompanied by symptoms of acute target organ damage, headache, blurred vision. In such cases, rapid and controlled reduction of blood pressure is crucial, typically achieved with a parenteral vasodilator like nitroprusside, labetalol, or nicardipine. These medications are preferred due to their quick onset and titratability in the critical care setting. For example, oral medications or those with slower onset would not be appropriate for the immediate reduction needed to prevent further organ damage. The key is to recognize the urgency and choose a rapidly acting agent. Question 23. A patient post-anterior myocardial infarction develops new ventricular ectopy, frequent premature ventricular contractions, PVCs. The nurse should prioritize monitoring for which electrolyte imbalance? A. Hypernatremia. B. Hypocalcemia. C. Hypomagnesemia. D. Hyperphosphatemia. Answer C. Hypomagnesemia. This question focuses on the connection between electrolyte imbalances and cardiac arrhythmias, particularly in the context of myocardial ischemia. Hypomagnesemia, low magnesium levels, is a common electrolyte imbalance in critical illness and is well known to increase myocardial irritability, predisposing patients to various arrhythmias, especially ventricular ectopy and PVCs. Replenishing magnesium is often a first-line intervention for new-onset ventricular ectopy. For example, if a patient's magnesium level is 1,2 milliequivalent/L, normal is typically 1,5-2, 5 milliequivalent/L, they are at higher risk for these arrhythmias. Always consider magnesium as a crucial electrolyte for cardiac stability, especially with ventricular arrhythmias. Question 24. A patient is on mechanical ventilation and has a pulmonary artery catheter in place. The nurse notices the pulmonary artery pressure, PAP, waveform becomes continuously wedged. What is the immediate priority action? A. Re-zero the transducer. B. Inflate the balloon with more air. C. Notify the physician immediately. D. Deflate the balloon and withdraw the catheter slightly. Answer D. Deflate the balloon and withdraw the catheter slightly. This question addresses a critical complication related to pulmonary artery catheter (PACI) monitoring, a continuously wedged position. This means the balloon is either overinflated or has spontaneously migrated into a pulmonary artery branch, blocking blood flow and risking pulmonary infarction. The immediate priority is to deflate the balloon and withdraw the catheter slightly to restore blood flow and prevent damage. For instance, if the waveform doesn't return to a normal PA waveform after deflating the balloon, gently pulling the catheter back a centimeter or two is necessary. Recognizing a persistent wedge waveform as an emergency is vital to prevent pulmonary injury. Question 25. A nurse is evaluating the effectiveness of intravenous nitroglycerin in a patient with acute coronary syndrome. Which of the following assessment findings indicates the medication is having its desired therapeutic effect? A. Increased preload. B. Decreased heart rate. C. Relief of chest pain. D. Increased blood pressure. Answer C. Relief of chest pain. This question assesses your understanding of the primary therapeutic goal of nitroglycerin in acute coronary syndrome. Nitroglycerin is a potent vasodilator, primarily reducing myocardial oxygen demand by decreasing preload and, to a lesser extent, afterload, while also dilating coronary arteries. The most direct indicator of its effectiveness in acute coronary syndrome is relief of chest pain, which signals improved myocardial oxygen supply-demand balance. While other hemodynamic changes occur, the alleviation of pain directly reflects its therapeutic action on ischemia. For example, if a patient's chest pain score drops from 8 out of 10 to 2 out of 10 after administration, it's clear the nitroglycerin is working. Always remember that pain relief is the key clinical indicator of effective nitroglycerin therapy for ACS.